Now, Dr. Kyle is a salaried GP with special interest in medical education. He explores these interests as an honorary senior lecturer at Swansea University Medical School, as well as being an honorary clinical teacher at Cardiff University School of Medicine. Dr. Kyle received his MBBS with honours from the University of Leeds, after which he underwent his foundation training at Bradford Teaching Hospitals NHS Trust and Calderdale and Huddersfield NHS Trust, respectively. Prior to his medical degree, Dr. Kyle received a PhD from the University of Leeds Institute of Molecular and Cellular Biology. He also holds a Master's of Engineering degree in Biomedical Materials Science with honours. Dr. Kyle is on the editorial board of two well-known peer-reviewed journals, Frontiers in Biomaterials Science and Frontiers in Medicine. As an avid researcher, Dr. Kyle has been involved in over 10 conference presentations and is named in an incredible 17 publications. He's also very passionate about supporting and educating younger people with mental health concerns. So thank you so much, Dr. Kyle, for speaking to us today.
Thank you for having me.
So I think I just want to get started by asking you to tell us about a typical day or even week as a salaried GP for you.
Yeah, sure. So obviously people will know about the clinical work that's involved as being a GP, and that generally involves telephone triage or face-to-face appointments. But alongside that, there is quite a lot of administrative work involved as well. And that can involve checking bloods and acting on them, going through referral updates, where I've referred a patient to a specialty in secondary care, and they've sent back an update regarding this referral. That may include a referral that's been accepted, which is great. They will see the patient according to the waiting list, and that's fine. But it might be stating what a diagnosis is most likely to be, and suggesting treatment options that can be initiated by me in primary care. Or it may be not accepted because it doesn't meet a threshold for secondary care treatment. There's also lots of time spent signing repeat prescriptions. And we will also be sent recommendations from specialists in secondary care to instigate treatment, which we need, to act upon. There's daily medication reviews, and that can often be done remotely, so you don't always need the patient in front of you to do that. We go through a list of patients' medications and check, such things as compliance, patients requesting medication too frequently, is the medication on repeat, understanding why, and importantly, should they be on that medication longer term? Maybe have they had recent blood tests, or if they haven't, do they need some blood pressure checks? And has the patient had any recent blood tests that have kind of highlighted that they may be a new onset diabetic? So, it's recently found out that they've got the HbA1c, which is raised. And have they been added to diabetic registers? Well, they'll have regular reviews and offer diabetic eye screening and podiatry input. So there's a lot of admin work, as you can see there. There's lots of medical student teaching, which, as you have alluded to, I really do enjoy. And in my practice, we have students from Swansea University, from different year groups, and they watch how I consult with patients, and then they're given the opportunity to practice. And, we debrief at the end and implement a management plan. I've got some students in with me today. I'm also the module lead for the Physician Associate course in Swansea University, and I deliver lectures to students themed around musculoskeletal medicine, but I particularly focus my teaching on presentations seen in general practice, such as osteoarthritis, fibromyalgia, gout, pseudo-gout, things like that. And I also give various case presentations with the students so they can build upon their knowledge and apply it to clinical situations. And the days I'm not working keeps me busy still. I'm writing a book currently, so this is a two-part book that was commissioned by Wiley. The first book hopefully will be coming out in the summertime. It's an MCQ or single best answer type book for medical students that focuses on the basic science, or what I like to call the foundation of medicine, particularly focused on areas that students often find really difficult, particularly in the earlier stages of a medical degree, things like biochemistry, pharmacology, histology, genetics. And then, hopefully that gives them enough explanation into the foundations, which can then, they can go forth, and this acts as an impetus to read more about the subject, to help focus on increasing knowledge. And then the second book, hopefully, will be coming out next year, and that's themed around clinical case studies. So that focuses on various medical and surgical specialties.
Perfect. I know medical students love MCQ questions, so I'm sure that book will definitely be a hit amongst them.
I hope so.
For those of us who aren't quite sure, can you differentiate between a GP and a salaried GP?
Yes, absolutely. So a salaried GP can sometimes be called a sessional GP. And ultimately, you have either a salaried GP, a sessional GP, or a GP partner. And currently, I'm a salaried or sessional GP, and that means that I work a certain number of sessions in a week. So I currently work 6 sessions, and a session is half a day. So I work 3 days a week, or 6 sessions in the week. And the other 2 days that I'm not working, I'm doing these other things, or spending time with my children, trying to do fun things outside of medicine, which is what we should all be doing as well. And then you've got a GP partner. So in essence, a GP partner is very much like a sessional GP, but the addition is that they are partners in the business. So they run the business. The thing is, with a salaried GP, I, do all the clinical work and the administrative work that a partner does, but I don't get any say how the business is ran. But that's what the partners do. So they have far more of a kind of the input into the managerial roles of a GP for sure. But the nice thing from that is that I've recently just been offered a partnership, and that starts in April. So I'm excited about. Thank you. I'm excited about the prospects ahead.
Sounds exciting.
I hope so.
Okay. You briefly touched on some of the tasks that you do as a GP day to day, so medication reviews, talking to patients, checking on referrals. But can we briefly discuss some of the common patient presentations that you may see?
Yes, of course. One of the great aspects of general practice is the variety that comes with the job. And since COVID, patients presenting with physical health problems are more and more experiencing mental health conditions for sure. I've certainly seen that in my practice. There's also good evidence showing that people with long-term mental health illnesses have a greater risk of poor physical health, and that can result in premature mortality. So we also must remember that many patients who've been prescribed medication in secondary care, which is often continued in primary care, they need regular monitoring, not necessarily of the medication itself, but the after effects of what such a medication can have on their physical health. And what I'm alluding to there is more of the cardiovascular disease and diabetes that can be particularly associated with things like antipsychotic medication, which can increase your risk of cardiovascular disease. And in this light, we must be mindful of the support we can offer patients in relation to things like diet and smoking habits and physical activity. But also important here is the barriers that these patients can often face in accessing healthcare. That's very, very important. Like you mentioned before, I'm particularly interested in helping younger people with mental health problems, and currently getting patients into secondary care services in all disciplines is quite an arduous task, that's for sure. The waiting lists are quite lengthy, but particularly in children's services or children and adolescent mental health services or CAMS is difficult, like others, due to lack of capacity. So these, there continues to be a significant increase in teenage suicide, and more must be done to help these people. So, that's a particular interest of mine. And we know there are lots of support agencies, and they can help with anxiety, low mood, emotional dysregulation, bereavement, for example. And I think I sent a post to you not long back that I created, which highlighted a range of agencies that can help in this regard, and disseminated this via social media, and had it printed, distributed around local supermarkets and public spaces in the Swansea area. What I feel is key is that we need to expand our support for mental health, not just in younger people, but adults as well. But we do need to focus a lot more on helping them in schools. I really am passionate about that. We're seeing a rise in children with autistic and ADHD traits, and we're doing these children and younger people a disservice if we do not get a diagnosis earlier, as we know that this can often impact significantly on their education and longer term health. And one of the things that is quite difficult in primary care is referring to CAMS for such things like ADHD assessment is not necessarily done via the CAMS team. It's actually done via the neurodevelopmental team, and referrals to them are often done via the school, via the special educational needs coordinator or the SENCO. I think in your first talk, when you were speaking to Olwen, interestingly enough, Olwen is a good friend of mine. We studied at medical school together.
Oh, is she?
Yes, she is.
Small world.
It's a very small world. So yeah, they're things that I'm interested in. Other things that are quite common in primary care, well, we've got diabetes. So this is mostly managed in primary care now, and often practices have a diabetes lead who manages these patients. We've got COPD and asthma, common conditions. COVID meant that COPD and asthma reviews were put on hold, but we're seeing these, slowly return to normal. And many practices have specialist nurses who can help manage these conditions, doing regular spirometry. But if not, they can be referred to secondary care. And this obviously all fits very much into chronic disease management, which is an important feature of primary care for sure. What else? Skin complaints. Skin complaints are very common in primary care. I read a recent article that stated each year nearly a quarter of the country attended a GP appointment about a skin complaint. So that's quite staggering.
That's a massive number.
Absolutely. And I have to say that dermatology is very interesting, but also very daunting at the same time. The worry often, what goes through a GP's mind is, is this something sinister? And I'm sure that's what's going through the patient's mind as well. Is this something that I have to worry about? But, most of these conditions, such as the common eczema, dermatitis, acne, psoriasis, they can all be managed in primary care initially. But when treatment options have not provided any benefit or they failed, then referring on would be the next step. And I certainly would like to see a move in medical education, particularly in undergraduate curricula and GP registrar training for sure, that helps move kind of this interest in dermatology, to educating people more, particularly trainees, particularly undergraduates, but also particularly GPs who have a specialist interest in dermatology, because I have to say some of the time it's a minefield.
So it does sound like there's quite a wide variety of presentations that you see, but I just wanted to go back and focus on mental health that we were talking about. So when I did my GP placement personally, I saw a few children and adolescents come in and their parents were quite concerned. But then I also got to see the frustration when the GP told them about the waiting times and access to services. So how do you respond to these parents and adolescents who show this frustration to you in your practice?
it's very difficult. And having to tell patients and families that the waiting list for whatever specialty that I refer to is lengthy is, very disheartening as a GP, because ultimately I would like on every occasion to help sort out, address the problem right there when the patient's in front of me or I'm having a call on the phone, and then that's the end of it. But that's one of the difficulties that we have, that the waiting lists for these things are so lengthy. Patients and family will often come back and say, well, if we had the finances, could we go privately for such treatment? And obviously there is that facility to do so. And unfortunately, in this instance, in the current climate with the NHS, money does pay. And I never really want to be saying that, but if you have the finances behind you to get treatment instigated quicker, then I think that is, an option going forward. The other thing that's quite annoying is that you do a referral and then patients have, waited, say, weeks to months, certainly more of the months situation currently, and then they still have not heard any word or correspondence from the hospital, and then you've got to go back to the patient and say, look, I don't have any more information, and often I do feel like we're just going around in circles. But this comes down to, in primary and secondary care, underfunding, and we've got to put more money into the system for it to remain viable longer term.
Okay. And when we talk about the teachers and their role in helping to highlight students who may have a diagnosis of autism or ADHD, do you think there's scope for GPs or clinicians to go into the schools and educate teachers more about the signs to look out for? Or do you think they're already doing a pretty great job at this?
So I think that's an excellent idea. The only difficulty that we have there is the time. Because the difficulty that we have in general practice is time is such an important commodity. We've got to be ensuring that we're using GPs with the right skill set to be doing the right jobs. Okay. Now, me going out into schools, I would very much enjoy that, and I would very much enjoy educating teachers and speaking to the special educational needs coordinators and students themselves. I absolutely would. But then what you've got to ask yourself is that takes you away from being a GP doing clinical duties, and that is the balance. As a GP, are you using your skills effectively, or could somebody else be doing that? And I certainly think there would be a role for support agencies to go into the schools, and I'm sure that there are, who are educating the schools a little bit more about these. And it is an important point that you raise there, because I have many patients who've said they've gone via the school and they're not getting anywhere, and this is a real problem because the person that's suffering is the child, and that's just not fair.
Yeah, it is quite difficult, and it seems like time is the most prized possession, but we have so little of it, it seems.
100%. Use it wisely.
Use it wisely, definitely. So we talked a lot about variety and you getting some time to explore other interests such as your medical education, spending time with family. So what do you think is your favorite part about the specialty?
That comes down to variety is one thing, which I really like. Being able to see and treat patients holistically, get to know them as people, and also we get to know their families. I think you'll be hard pressed to see any other discipline where in one consultation you could see a 1-week-old, and in the next consultation you could see a 100-year-old. And that really still gives me goosebumps now when we talk about it, because I'm very privileged to have to be able to do that. It's about working with patients, their illnesses, and being able to tackle the social impact on health. That's very, very important. And I feel as a GP, I'm a patient advocate during difficult times. And this to me is far more intimate than what I would be getting in more of the secondary care setting, where I did feel things were a little bit more transactional in nature. And I like that aspect of it. The other thing that's important, and the one thing that, again, is exciting, but again can be quite daunting, is you're developing your clinical acumen in the absence of readily available investigations. We're very limited in what we have in general practice. And, you know, I like to say the weapons in my arsenal are a stethoscope, a temperature probe, a pulse oximeter, a sphygmomanometer, an otoscope, a tendon hammer, a urine dipstick testing strip. We don't have easy access to bloods. I can't request an X-ray immediately, have it looked at, have it reported. It just doesn't work like that. So I've certainly got to think more on my feet quicker, because I don't have the immediate investigations to help answer the questions that I have in front of me. So that's, you know, that I think we have to be very good at risk stratification in general practice. So I've got a patient in front of me. I've got to make a decision relatively quickly. Is this patient going to become unwell very quickly? Is this patient unwell as I see them in front of me? Or is this something more benign in nature and we've got time to treat it and try different things? So I think you really do develop those skills in general practice, and I do find that exciting. There's certainly a greater element of autonomy compared to when I worked in a hospital setting, that's for sure. You are your own boss. You still have to work to a contract, but you decide on how the structure of your day goes, how the structure of your week goes. So, you know, if I want to do some admin in the morning and do some of that, and then start triaging, bring patients in to be seen, then do a bit more admin over lunch, I can do that. I don't have to have a set agenda all of the time. You can work with colleagues far more closely. I know many people. I think your second speaker said that they weren't too content with the kind of enclosed nature of being a GP, because you're kind of isolated in your room, but you really do make of it what you can. You know, the partnership that I'm entering, the place where I work, I love working with everybody there. We have a, you know, great camaraderie. We have tea breaks that we try to, you know, implement into our day. I have to say they don't always go to plan. I do have an 11 o'clock to have a break, but I can't think that I've taken it yet. Lunch times is a good time to get together, but again, I do, and it's probably my own fault because I should just take my time away, but I'm doing work whilst I'm having my lunch, and I know in medicine we should never do that. But the thing is, if you didn't do that, the amount of, you know, clinical and admin work that you have during the day will exceed quite quickly into the evening, and you could not be leaving till sometimes 7, 8 o'clock at night, and you know, you don't want to have the risk of burnout. What else? Yeah, I mentioned about variety. That's one big thing for me. There's the other thing that is related to GPs with specialist interests. So for me, I have a specialist interest in mental health, and particularly with young people. But you can have specialist interest in cardiology and dermatology, rheumatology. People can go and work in MRU if they wanted to, the minor injuries unit. Sometimes I do out of hours sessions on an evening or at weekends, so there's scope for that. There's also scope for being more business minded, and you know, becoming a partner in April, I'm certainly going to have to read up more on accounts and how finances work, which again, I have to be honest, is a bit of a minefield. I'm hoping we have a good accountant to deal with that. So yeah, hopefully that gives you a good flavour of the diversity within general practice, for sure.
It does, and I think it's quite interesting because prior to my GP placement, I didn't know that GPs could undertake special interests. So knowing that that is an option, hopefully, um, entices people who may not have been thinking about doing GP before.
I hope so.
And hopefully, and referring to what Dr. Strauss said about being in a room and not interacting that much with colleagues, I think it's also important to reflect on your personality and whether that's something you prefer or not, because as you said, practices are different. And if you like to work alone, maybe it's good for you, but then there are practices where you do work as a close-knit team. So it all depends, doesn't it?
100%, absolutely. And sometimes it's nice to have a mix. Sometimes you just
Mm.
want a little bit of time to yourself, getting on with the task in hand, and that's absolutely fine. But the great thing is that you can go to the next room, knock on somebody's door, and say, "Would you like a brew?" And that's just as nice.
It does sound nice. And you also mentioned the fact that you must be very resourceful. You only have a limited amount of tools in the practice. And after a certain point, you have to refer them on to secondary care. Do you ever find it a bit frustrating? I guess that's the word I'm thinking about, not being able to do a bit more diagnostic investigations in practice.
uh, yes, but I do find that my clinical acumen has improved a lot more, um, because I have got a limited number of resources. Because if I had all of these other things at hand, I could be spending nearly an hour with a patient doing X, Y, and Z and trying to do this and trying to do that. But then again, that takes me from seeing the amount of patients that government want us to be seeing. They want us to be seeing more patients. They want us to be seeing them in relatively shorter period of time. So people who can get an appointment can get an appointment sooner. But then if we started doing more of these things, then we wouldn't simply be able to see that sheer number of people. So I think
Hmm.
you've got to put it into the perspective that there is a place for a phlebotomy service. And yes, you could have it in your practice, and many practices do. But you could then ask yourself the question, well, is it not better that, say, a healthcare assistant would be doing another task where that would actually be more helpful to the practice, and actually just giving the phlebotomy service to a local centre, which is often what happens in the Swansea Bay area, that's for sure. We can just send people, they can book online to get a blood test. If they're urgently done, they're done via the admin team. In my practice, they ring them up and you can get an appointment for a blood test if it's urgent, sometimes on the same day. So I think that, if there is a need, and I think that's really important about talking about clinical need. If there is a need to have urgent bloods, we have the facilities for it. And I think that's really, really important. But yes, I mean, there are some super practices in England. They have at one end a physiotherapist, an occupational therapist. I think at the other end they have a nursing home. They have literally a whole
Wow.
variety of resources within one particular practice, and that's great. But it's not a common thing, that's for sure.
Yeah. I haven't seen one in Wales where I've been so
No,
far.
me neither.
You briefly touched on the NHS and government targets for the patients you see in a day. So I think that leads into, can you tell me a bit more about the current public image of GPs? Can we discuss that?
Yeah, absolutely. And this is a problem, because the impression from the media, negative outlooks, denigrating us, not respecting, GPs and their limits to workload. They don't quite understand what GPs do, I think. And the public perception, often is that we are overpaid, we don't do enough work, or we don't work enough days. But hopefully, I've alluded to the fact that when I'm not seeing patients, I'm certainly not sitting on my backside. There is an incredible amount of bureaucracy associated with general practice, and in particular in secondary care also. There's a lot of tick box exercises, and this prevents us stopping doing our job. And that's a real shame, because what I love is seeing patients. That's what I came into medicine to do. I'm not a manager in that sense. And yes, becoming a partner, you have business and managerial responsibilities. Yes, you have to manage people within your practice, but you're still set to a contract that's set out by policymakers, by government, Wales, NHS Wales, or in other devolved nations in Scotland or Northern Ireland or England. And I think this really does give general practice such a negative light. And it's not really like that. We're working incredibly hard to try to serve the public. And, I think we need more support and we need more funding to ensure that general practice continues. And I think that's really, really important, because we should never lose sight of the fact that general practice is the front door to the NHS. And if general practice fails, the NHS fails.
I think it's also important what you said, because you often hear patients talking about their frustrations when they call the GP and they can't get an appointment. And while that's completely understandable, especially if you're in pain or you just feel generally unwell, I think it's important to understand that the problem and the backlog doesn't begin at the GP practice. It's also heavily related to the framework and the funding that you're being given. So while the frustrations are completely reasonable, I don't think putting the blame on the GP practices is entirely fair.
Absolutely. And to follow on from that, for me as a GP, I completely understand their frustrations with access. If I was not a human being and a robot doing this, there would be endless amounts of consultations and access would not be a problem. But unless you, restore faith in general practice, and that has to come from a change in media and an opinion that's portrayed by the media, because unfortunately often it is vitriol, and they really don't quite understand what we're faced with in our day-to-day practice. And there's many documentaries that come about online, and on the TV. And I welcome anybody come and spend a day, a week, a month with me in general practice and just see what exactly we do. Because I can assure you, we're not just sitting around, and it's not that we don't want to see patients. We absolutely do. But it's got to come from the powers above, and it's got to come from government and the policymakers. If patients have a problem with access, we feel your pain, that's for sure. But really, the people who it would be best to be complaining to would be MPs, because they're the only people that can get these concerns back to government, and we can see changes happening far quicker than what we're seeing at the minute.
Exactly. You also mentioned people sometimes thinking that when you're not seeing patients, you may be just sitting doing nothing. But I think it's important to say that it's okay if you're actually sitting doing nothing, because burnout is a real thing and doctors need to have a break and relax in order to put their best forward for their patients.
100%. If you can't look after yourself, you can't possibly look after patients. And that's a really, really important take-home message, is that. And for me and one of my colleagues, at lunchtime, sometimes we do go for a nice walk around the park. He'll sometimes nip to the local shop and get some fruit, and we have a chat about life, and we have a chat about our sometimes morning clinic. The difficulty is, as you'll know, in medical school and as a medic, it doesn't matter what setting you're in, you always get back to talking about medicine.
Medicine. Yeah.
It is inevitable. And we do try to stop doing that. But it is just inevitable. And I think it is a good thing because, you've got that freedom to run ideas by people. And when people say in general practice, you are quite isolated, I really don't feel like that because, yes, I'm in a room with, 4 walls, but I can knock on the door of any of my colleagues and say, look, I've got this patient in here, this rash, I've never seen anything like this before. Would you mind coming and having a look? It's never an issue. And I would absolutely encourage that in medical school, as medical students progress, junior doctor years, as trainees. If you don't know the answer, it's best to say you don't know the answer. It's best to find out ways of getting the answer, speaking to people who, might be able to shed light on the situation. But don't lie about it. It's it just gets you into more trouble. It's best to hold your hands up, say that's the problem, and then work out what's going on.
Sometimes as medical students, we can actually be a bit embarrassed to admit that we don't know something. But I think it's important to put our egos aside and understand that we need to clarify because for the patient, it's for their best interest and not worry about how we are going to be perceived.
Absolutely. And not just in medical school, as doctors as a whole.
Yeah.
I do not have all the answers. And I will hold my hand up and say I do not have all the answers. But when you're thinking about stratification, you're thinking about risk, I'm really kind of putting the situation on a scale. And is it a low risk? Is it high risk? Is it in the middle? Is this something that needs dealing with at this moment in time? That's high risk. Is this something that we can say, well, let's give this a try? It's very unlikely to be that. It is more likely to be that. And it goes back to the balance of probability, doesn't it?
Yeah.
And that's one of the things that we have in general practice. We have that time element. That's why safety netting is so important in our job. It's not just something that we're saying at the very, very end of the conversation, oh, if you don't get any better, come back and see us. It's really, really important because we have the time element to say, well, in 2 days' time, if there is no improvement, if things have got massively worse in that period of time, please get back in touch with us.
Okay. So just delving into a bit more about we're talking a lot about the specialty and what it's like currently, but can you just give us some insight into how the specialty has evolved from when you first started until now?
Yeah, sure. So I started general practice at the tail end of COVID. So I've been in as a salaried GP for a year now. And prior to that, I was a GP trainee. And like I said, I've become a partner and start that role in April time. And COVID has meant general practice has had to reconfigure its operating model at a fast pace. That's the first thing to say. We saw a huge increase in remote triage and far less face-to-face consultations. And it's unlikely that these numbers will return to their pre-pandemic level. That's very important to highlight. And we have to be mindful as to why this is. Many patients prefer remote consultations. That's one option. And I think that's important. It's an option, isn't it? We have got to give patients choice. That's our job. We're not living in a paternalistic society anymore. We're not saying, you must do this because I'm a doctor. We must not be doing that. That's not where we are. It's a partnership, isn't it? It's shared decision making. And there might be issues with mobility. So, some people want to chat on the phone. Some people might want to do a video consultation simply because of mobility issues. Those who are unable to take time off work, that's often far easier if you can give the GP a ring, or we can ring them and have a chat over the phone. And often, because my interest is in mental health, I see many people with worsening anxiety, particularly severe anxiety, and certainly related to social anxiety, who don't want to be seen face to face. They'd rather have that consultation on the phone, because if they do go and see somebody face to face, it worsens their anxiety. So, there is a place for face-to-face consultations, and there is a place for remote triage. And I want patients to understand that. If somebody has a chest problem, if somebody has an abdominal problem, I think you'll be hard pushed if you didn't really go and examine them and say, look, I need to examine your stomach and I
Yeah.
need to examine your chest. It'd be very difficult to say it in court if you didn't do that, because you can't really listen to a chest or examine a tummy over the phone, that's for sure. There's currently more GPs in training than ever before. But even if this continued and these trainees entered the profession, it would not be enough to counter the numbers that are leaving the profession. And this is a real problem. And this really does come down to bureaucracy. And we want to see less bureaucracy, we want to see less tick box exercises, we want to see unnecessary administrative burdens imposed on general practice. So ultimately I can spend more time in doing the part of the job that I really, really love, and that is seeing patients. And I also want to emphasize that, as GPs, we want to deliver safe and timely care to patients. And it's frustrating to us as it is to patients regarding this accessibility problem, like I've said. And, again, I'll go back to the media. Why is it often not portrayed in the media why this is? Well, we have an expanding population. We're trying to deliver high quality care to patients with complex clinical needs, that's for sure, and with fewer resources and a declining workforce. So we have to be mindful of the fact that I too am only human. I'm not a robot. And if the conditions continue within general practice, it will only lead to further GP burnout like we've talked about, and more leaving the profession. And yes, we have to call on government to help drive recruitment, that's for sure. But we have to also ensure retention of the GPs. There's no point in bringing more people in if we also having people leave. It's like that bath model, isn't it? You can keep the bath filling up, but if the plug is not in place, then it makes no difference to the system. So we need to change the current conditions. It's not sustainable. And, if government listen to us, we will make it better for patients. That's the key to it.
It sounds like having, for instance, a documentary highlighting or following a GP even for a week, so that patients and even the public can watch it and actually understand, then their perspective might actually change and pivot from being against GPs or blaming GPs to actually working together with GPs and rallying and advocating for the government to make the necessary changes.
And I would be happy to act as the conduit. Because I absolutely agree with you. If people could only see what we are faced with, particularly, we've seen many documentaries on TV that do focus on kind of the clinical side of what it's like being a GP. And that's great. But if people understood what administration is involved in being a good GP, and the government want us to see more patients, but more importantly, is it a balance? How do we restore that equilibrium? Is it about quality? Is it about quantity? And for me, it's always got to be about quality. I can probably see 1 to 10 patients very, 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 very well. But as you increase that number, 10 to 20, 20 to 30, I'm going to be able to offer far less better treatment when I'm seeing more people. And that just does not seem sensible to me.
Well, in addition to your 2 books, I sense another project brewing.
That would be very nice. I do like a project, as you've seen.
Definitely. So what resource would you recommend, if any, to students or junior doctors who are thinking about entering GP training?
Okay, so I think the key to that is getting involved with medical societies locally. So most universities and the medical schools have, GP societies that you should, get involved with. Medical students will have GP placements. But if you feel that you've not had the best experience and, I'm really hoping that's not one of our practices, that's for sure. We do get good feedback from medical students. But if you don't get the best experience from a particular practice, please don't be disheartened. You know, if you want to learn more about life as a GP, get in contact with a particular GP, contact me, more than happy to have anybody come and shadow me. Contact the practices directly, contact the practice managers. You know, they'd be happy to get on board. And, you know, any aspiring GPs, get in contact with me, shadow me, see what we actually do. That's absolutely fine. And remember, you know, I was one of those students. I categorically, interestingly enough, said I would never become a GP. And as
I
you
would
can
never
see
have guessed.
as you can see from my CV, I was far more, let's say, surgically orientated, doing a PhD in you know, regenerative medicine, some molecular biology. I very much was an academic for sure, and I still do like that aspect. Particularly as a kind of a clinical academic. I enjoy writing articles if I see interesting cases. I'm currently writing an article with some ENT surgeons and some radiologists about complications of acute sinusitis, because it's interesting to, you know, disseminate this information. If you find a good study, you think, hang on a minute, people would really benefit from understanding how that patient presented and what was done afterwards. I think that's a great thing to get medical students involved with for sure, but, you know, even trainees. It's very good for your CV, that's for sure. But, you know, part of the reason that I didn't want to do it was because of the variety. I was scared that how am I meant to know so much about so many things? And I think that's the key, that, you know, we have specialists, but you will hear many people talk about, particularly within the Royal College, talk about generalists. We're specialist generalists. So we do know a little about a lot of things, and I think that's okay, because we have specialists who know a lot about that particular thing, and as long as we have that system working well, it will continue. And you know, we've got to remember that when we're GPs, we're kind of saying, well, is it likely to be this? It's unlikely to be this. You've got the safety netting associated with it. And, you know, remember, as a GP, I don't really have a magic wand, as much as I'd love to fix everything. It's just simply not possible. And we're gatekeepers, and we have this shared mutualistic relationship with patients. And often it's, you know, let's give this a go, let's give that a go. We can try this, we can try that. But if things don't improve, you know, we can think about other agencies, other specialists who can get involved, that's for sure. So the key for me with students and, you know, foundation doctors for sure is, you know, give it a try. I will meet many patients, many students who come in to general practice, and they absolutely do not want to be GPs. They sometimes don't even have to tell me. I can see it on their face.
You can just tell.
I can just tell. But often I really do like to change, not just the career path, but just to appreciate what resources we have in general practice. And I think that's really, really important to understand, that the resources are limited. And you certainly do build on your clinical acumen far more, I personally think, in general practice because of these limited resources, that's for sure. So yes, get lots of experience, get involved in societies, contact any GP practices, and many will be happy to accommodate, that's for sure.
And for those who are interested in becoming a GP, can you just let them know, what is the training pathway like?
Yeah, so it's a relatively straightforward training pathway. So you can do your medical degree, whether that be 4 years graduate entry or the 5-year course. You do foundation training, so 1 and 2, and then you can get onto a GP training program. And currently that stands at 3 years. I think there was some talk of changing it to possibly 4 years. There has been a shift in Wales where they're often 6-month placements, and there was less general practice rotations and more secondary care. And one of the difficulties, and this certainly was fed back to training program directors and people higher up in the NHS, that often GP trainees are used more as a service provision in secondary care and weren't really, having the true kind of GP experience.
Mm.
So now trainees have a year in secondary care, so that could be like obs and gynae. It could be one 6-month placement in psychiatry. It could be ENT, ophthalmology. So 2 6-month placements in the year, and then everything else that follows is mainly general practice themed. I am told though that 6 months can be rotated around the 3-year period. So you might get 1 6-month in a hospital, then a GP practice, and then another hospital placement, and then it finishes with a GP practice. So I think there's certainly been a good shift for sure, because at the end of the day, if you're training to be a GP, you want to get more hands-on GP experience, right?
Yeah, I would hope so. And when you spoke about the pressures that GPs are under, it just made me think about, what do you consider to be the personal and even professional sacrifices that GPs have to make?
So I think being a good GP certainly requires a certain skill set. The ability to work long hours, often under pressure, be empathetic, have an ability to spot and solve problems in an efficient manner, have an element of business acumen, be organised and meticulous. I think that really encompasses the best GP that you could probably get. So I've always wanted to strive to be a better doctor, and I'm always learning. That's what I love about being a doctor. I'm always learning something, and I that's not necessarily through the knowledge that we acquire, through medical school, but I learn lots from patients. Patient stories. I often say that being a GP, actually, I'm just being very nosy because I'm just so inquisitive about people's lives. But I think that's what you need to have if you're a good GP. You need to know, what's going on with you, what's happening in the nuclear family, what's happening in the extended family. It certainly is a partnership for sure. And I think when that moment stops in me, wanting to strive to be a better doctor, it's the moment I have to leave the profession. Professionally, it's very difficult, but sometimes necessary to say no to patients. And that is really, really hard. We have to be mindful that there's a huge difference between what patients want and what they actually need. And professionally, there is a lot of sacrifice in this regard. Sometimes communication can break down, but we have to understand that we don't have an infinite amount of money. We don't have an infinite amount of resources. If everybody was to request an MRI scan of the head, that just would simply not be possible. And the amount of times that people have a headache and they have something that is more worrying is very, very, very small. Not impossible, but very, very small. But we couldn't possibly request CTs and MRIs of the heads all of the time. And on the other side of the coin there, would you want to be CTing somebody's head over and over again with the amount of radiation that you get from it?
Exactly.
I think one study said that there's, 1 in 10,000 CT scans of the head, you will then cause a brain tumor from doing that. Yes, it's small, but the risk is still there for sure.
Yeah.
So, potential sacrifice of communication breakdown, that is an issue when you're having to say, look, what you want and what is clinically needed, that can be a real difficulty. Doing unnecessary tests, which is, sometimes we just can't possibly do all the things that patients request. People might have side effects from something. On a personal front, undergraduate and postgraduate training certainly requires resilience, and the balance between personal and professional life can often be distorted, that's for sure. And we've got to rebalance the equilibrium, because, my advice, if anybody's listening to this from medical school, as junior doctors or in the public, ensure that you work to live and not live to work. Caring for yourself and your loved ones at home is just as important as caring for your patients. Please never forget that. That's certainly a take-home message from me, for sure.
I've often heard some of my colleagues saying that they're considering being a GP because they want to have a family life. But I wonder if they underestimate the amount of work and the burden that GPs are currently under. How would you respond to that?
I think if anybody wants to start a family, in whatever discipline you do, please do not let the discipline hinder you doing it. And, I read many articles, many on social media, who talk about women in particular who want to take time out of surgical training, take time off maternity, and we're still living, which we absolutely should not be, in an era where, unfortunately, male surgeons, a few of them, I'm hoping this number is getting very, 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 very small now, who do, frown upon this, and this is quite wrong. If people want to have children, great. If people don't want to have children, that is absolutely fine. It should not dictate how you progress in your career. And I really want to get that message across. It's really, really, really important. In general practice, yes, we don't have the weekend work. We don't have the nights. So it is far easier to have children, have a family in general practice. I certainly would say that. But even in secondary care, if you want to have a child in your 20s, if you want to have a child in your 30s, at whatever level you are in your training, please don't let the discipline hinder your progression, for sure.
Yeah, don't let it hinder your progression or exploring other hobbies.
Absolutely. Yeah, absolutely.
Okay. So we're coming towards the end of the podcast, and when I came up with this idea, I knew that if you weren't interested in a particular specialty, you may not listen to the actual episode. So I tried to include an advice section that anyone can benefit from. So we're now delving into that a bit. What would you say to a medical student or a junior doctor who's a bit overwhelmed at this point in their career path?
Okay. Anybody that's overwhelmed, whether that is professionally or personally, my advice is to seek support. If you're struggling, again, professionally or personally, help is at hand. Speak with the university or educational supervisors. Speak with friends. Please do not suffer in silence. Every doctor I know has struggled, has been overwhelmed at some point in their lives, whether that be personally or professionally. And it's okay to be not okay. That's really, really important to understand that. Take a break. If this is not possible, take a holiday. Refresh and reset. There's light at the end of the tunnel, but do not remain overwhelmed alone. There is people out there who are in a very similar situation, and sometimes talking about it really does help.
Dr. Strauss actually mentioned something very similar in the previous episode. So take their advice, everyone listening, because it seems to be popular.
Absolutely.
And thinking back, what would you have done differently, if anything, or what would you have done the same in your journey to becoming a salary GP?
Well, as when we started the podcast, you can see I've had, let's say, a meandering journey. But it's made me the person I am today, and I have no regrets. The skills I've acquired in my academic career through my PhD has helped me embark on other academic projects, journal writing, writing book chapters, writing a whole book. And I also think, entering medicine later in my life has been a positive for me. I certainly entered with a more mature attitude, that's for sure. And this was often well received by patients when I was a medical student, that's for sure. And in my junior doctor years, I probably should have listened more to my mentors when I was in medical school and in my junior doctor years, who said that I was destined to be a GP. I'm not quite sure about that, but where I am now, I'm happy. And I think being happy in your job and happy in your life and having that balance between work and personal life is incredibly important and should never be forgotten.
So even if you don't take the straightforward route, you still gain a wealth of experience from the different opportunities that you've undertaken to reach your final destination.
100%. These are transferable skills. They will help you in all aspects of a medical career, but going from an engineering to a PhD, many of the skills learned there equip many for scientific roles in business, in certain areas of the pharmaceutical sector. So these skills are always very, very, very important for sure, and they've certainly helped me.
Now for the final question, and I'm always very intrigued to hear what the response is going to be. What is the best piece of advice that you have been given that has shaped you as a clinician?
I talk a lot about time, and time is really, really important to me. And when I was in sixth form, there was a tutor, and I think, if I remember rightly, his name was Mr. Ferguson, I think. And he once said to me, one of the most important things that you can give anyone is your time. And I think that has, stuck with me for such a long time. Time's such a precious commodity. Policymakers want us to see more patients, but are we not compromising quality over quantity? Like I said before, for example, I could probably consult with, a smaller number of people, but that would help the quality of the consultation. But seeing more would be, potentially have a negative effect on seeing more and more and more patients because you're having less and less time with them. So I think ensuring that you think about time in your professional and working life is really, really important. What do you want to get out of life? When you look back, if you do have children, are your children going to thank you for all the hours that you worked? Or are they going to thank you more for the time that you spent with them and ensuring that you did work, but to ensure that you have a nice quality of time with them when you're seeing them? And it's important to have a very good compromise. So, just one little note following on from that. I know this is the end of it, and I'm digressing a little bit, but okay. Just to reinforce that, I recently saw a patient who I spent an hour with, and people could come back and say, "Gosh, an hour! I mean, how is that possible when you've had so many patients to see?" And this person had not opened up to anybody about their mental health problems, and they sat in front of me and they just cried, and I just let them open up and just sit there and cry a little bit more and just let everything out that they wanted to let out. And I didn't have any interruptions from myself. I just sat there and just, it's that, the active listening that's really important to us as medics, that you're sitting there and you're having the head nod. But, people talk about head nodding, it's not just there to be yes, 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 head nodding all the time, very oddly. It's about listening to their problems and allowing you as a GP to be brought into their lives for that moment in time. And that is really such a huge privilege. And I never underestimate it.
I'm glad that you brought that up and digressed a bit, because I wanted to ask you, what time frame do you think would be an ideal amount of time for you to spend with each patient?
There isn't one. There absolutely isn't one. And I don't want any policymaker coming to me to tell me that you should be spending 10 to 15 minutes with a patient. My counter argument to them is I will spend as long as I need with a patient to make sure that I'm giving them the best care possible in the time frame that I feel appropriate. And when I see and speak to a patient at the beginning of my consultations, in my sessions, whether that be the morning or the afternoon, I want to be giving the same best care that I give to the first patient as I do to the last.
I think that's a really strong point to finish on. Thank you so much, Dr. Kyle, for speaking to us today. I learned so much about being a salaried GP and about medicine in general, and I hope everyone that's listening did too. So please give us your feedback. Any questions, feel free to comment and come back for another episode of A Doctor's Insight. Thank you.